also joined on the line by Medical and Health Services lawmaker Dr. David Lam. Good morning, Dr. Lam.
Good morning.
Thanks for joining us on the program. Just now we were talking about some of the measures announced by the hospital authority to ensure patient safety while waiting at public hospitals. For example, stepping up surveillance of toilets and waiting areas, and the possible use of tracking technology. And our guests just now, Dr. Lee and also Mr. Lam, they also talked about the possible channeling out of patients to other departments. What's your view of all these measures?
Well, most of these measures are technically feasible, but sometimes we just don't have those technology at the moment. I think Dr. Lee works in an emergency department, so he knows well with first-hand information. I think we still remember some years ago, there has been a pilot project of stationing family doctors or general practitioners next door of A&Es. But it didn't work out, so people just don't want to go across the street to see the GPs, daytime or nighttime. So eventually they scrape the project, and then they're left with what they are. Now, there are some problems with our emergency medical system. First of all, it's heavily understaffed, and we all understand that. And secondly, the triage, they do not send people away. They just give priorities. So Category 4, Category 5 patients are really non-emergency patients and can be seen by their family doctors either the same day or even after several hours if it happens in the night time. But still, the practice is not to send them away and not to advise them to see their general practitioners or the family doctors, but ask them to wait. And that could sometimes take hours. And we must understand that triage is not like you're seeing a patient, making a full diagnosis. Triage is triage, and something can go wrong with triage. So if you have too many people around queuing up for the triage, some of them might have a serious illness, and some of them might be relatively mild. So with that number, the sheer number of patients, there has to be some problems when times go by. And you may have one or two cases who are really should belong to a high category, but then you wrongly assign them to a lower category because there's just too many people around.
So do you think that might have happened in this case then?
I do not know. But one thing is that if we have a habit of, if people have a habit of, if it's not serious disease, then go and see the family doctor. And if the emergency department has the right of not only putting them low down in their priority, but actually telling them, no, please, you go and see your family doctor. This is not the place for you. Then we are left with less patients, which is a more manageable situation. Now, this is nothing new. It is new to Hong Kong, but I have been to Australia some years ago, and a friend had some very minor allergic rhinitis, and he went to the emergency room. I don't know how he managed to get to the emergency room, but anyway, he was there, and he was asked by the nurse to go away. Just take some medicine from the pharmacy or see your family doctor. So with that kind of measures, the number of patients waiting to see the emergency room is more manageable.
Okay,
so that has been something we have been talking about for years, but nothing happened.
You say, but it happens in other countries, but for Hong Kong it would be a fairly radical change. You can imagine the public opposition to the idea that if you turn up at an A&E department, you might actually be sent away. It would be a major you need a new mind paradigm to have that in Hong Kong, surely.
Well, that's why we have to put that together hand in hand with the development of primary health care. When everyone has his own family doctor, and for people really from the grassroots population, that is subsidized care, then why not go to your family doctor if that takes a shorter waiting time, and he knows lots about your background history. Well, maybe the family doctor noticed in some of the background history that, hey, wait a minute, you could have some serious problem, although your symptoms are very mild. So I write you a note, and you take that note to the emergency room. So that maybe it hastens up and put them, and the triage nurse, after seeing that note, would put her or him in a higher category because of the past history known to him, known to the family doctor, but not to the triage nurse.
And
so
what happens?
Family medicine helps.
What happens to patients like this? This woman, it's the middle of the night. There's not going to be any family doctor open in the middle of the night.
Well, in the middle of the night, it's a bit difficult. But if people have illnesses and people who turns up in the middle of the night, they could have illnesses in the daytime. Okay, and if those people go and see the doctor earlier in the daytime, the family doctor in the daytime, they could have it treated earlier. And sometimes people feel sick after dinner time, and that is a problem. But our general practitioners usually open their clinic until about 8 or 9 p.m. in the evening, so pretty late in the evening. So I hope the usage of family doctor increases, and if that helps, at least in the daytime or towards the evening, that reduces the number of cases rushing to the emergency room, and that makes everything more manageable in the emergency room. So leaving the resources to the really necessary people. But of course, there are always possibilities that the triage nurse misses something because it's just not the full diagnostic evaluation. That's why sometimes family doctors help by giving you a history. Hey, something is wrong. You have such and such background. Better, I write you a note, then go and see your emergency doctor.
All right.
So in that way, I think it helps.
Okay, Dr. Lee, what's your view on that? I mean, do you see this? Do you share Dr. Lam's view that there's some problems with the triage system, and that maybe some patients with less serious symptoms should be sent away?
Yeah, I totally agree with David's comments because I remember in the last week I saw a patient who he's a gentleman who is categorized category 4, and then he has been waiting on a stretcher for a long time. So when I go and see him, and then he was complaining of dizziness. And then when I further asked question on him, he said he has a persistent headache. So I do a CT brain for this patient, and then I find out that he has a intracranial hemorrhage. So it is basically difficult to make a quick decision whether this case is an urgent or non-urgent case, because basing on simple things like the vital signs is not always reliable. I remember that gentleman having a hemorrhage in the brain. His vital signs are all normal, just complaining of dizziness. So this is a very difficult situation. In a short period, at the triage station, the nurse can only see the patient for just, say, 5 minutes, measuring the blood pressure, asking what is your problem, and then just throw in the record, and then waiting for the doctor to see the patient. So this is one point. The other thing, telling the patient to go away may be difficult at the night time. I'm thinking about whether we should increase the manpower of the accident and emergency department at night time, because actually we are short of medical staff at the night time. In the morning, say, we have a number of doctors with some senior grade coming to see the patient at our department. But at night time, in our department, we only have 2 doctors at night time. And then we only have a few nurses, just maybe 5 or 6 nurses to run the whole department. So I don't think it is satisfactory, because many patients are still coming in at night time. And then even we have to do more to clear out the patient left behind from the afternoon session. So it is really a difficult situation. I'm thinking whether HA should increase the manpower of the medical staff there at night time, and also invite more senior staff to stay at night time.
But presumably night shifts people do them, but they're less popular than day shifts. You're already facing sort of a loss of manpower in the HA. If you're putting everybody on more night shifts, maybe you'll accelerate the numbers who are leaving.
Yeah. So as Alex has mentioned, we welcome all sorts of resources we have, including the mainland medical staff and nursing staff. We all welcome them to come, because we really short of people to run the department. But I heard that the new staff coming from mainland just are assigned to do jobs in the medical ward. in the geriatric ward to see the elderly patient. So nobody is coming to the accident emergency department at this juncture. So we are still facing a big problem.
All right, Dr. Lee, let's continue talking about the GBA Health Talent Exchange Program after the news, because we have to take a quick break. And if you want to ask questions to our guests or just share your views on today's topics, you can leave a message on our Facebook page, Backchat on RTHK Radio 3. Email us at backchat@rthk.hk or give us a call on 233-88266. And here's a quick look at the weather. Mainly cloudy with showers and a few squally thunderstorms. The top temperature will be around 27 degrees. Winds moderate southerlies. At the moment, it's 24 degrees. Relative humidity, 95%.
Total COVID-19 vaccination stations.
Welcome back. This is Backchat on a Thursday morning with Danny Gittings and me, Janice Wong. Still with us on the program is Dr. Aaron Lee, an emergency ward doctor and medical and health services lawmaker, Dr. David Lam. Now, Dr. Lee, just before the news, you were talking about medical workers from Guangdong. You said, according to your knowledge, you'll be assigned to geriatric wards to look at elderly patients. So are you saying that it won't really help relieve pressure at emergency wards?
Yes, because as I heard from the news, there's still nobody coming to the accident emergency department to help out. Yeah, so it is quite disappointing because at the moment we are facing a lot of pressure, not only the number of patients but also from the expectations of the public. I recall many years ago when there was a patient outside the hospital. In one of the public hospitals collapses, and then the son finds the father collapsing on the street, and then he just run into the hospital and ask for help, and then nobody cares to take the gentleman into the hospital for active resuscitation, and the patient died on the street. So at that time, the public expectation is, whenever you saw somebody collapse, you should help out as soon as possible. But this time, the lady is collapsing in a toilet inside the accident emergency department. So I'm thinking, what's wrong? What can we do more to prevent this tragedy from happening and again and again?
But this latest case is a bit different from that earlier one you mentioned. I mean, the earlier one you mentioned, people saw the patient collapsing and didn't do anything about it. I think everybody agrees in this case that if the hospital staff had known that the woman had collapsed in the toilet, they would have done something about it. The problem was that they didn't know because they don't have they're not checking regularly enough, or they don't have panic alarms and so on.
Yeah, I agree. Maybe not only the panic alarm, maybe how about we have so many new technology. How about giving them a wristband that can measure blood pressure or doing some checking? If the patient do collapse and then lost the pulse, and then there may be an alarm to notify the nursing staff, somebody has a big problem, so you have to find this patient as soon as possible. That may help also.
Okay, and how about overseas doctors who are being hired? We hear that 20 doctors have been hired from the UK following the recent visit by the Health Secretary or the Hospital Authority. Presumably when they come to Hong Kong, they'll be put into work in work-like accident and emergency departments, so that will help a little bit.
Yeah, hopefully it will help, but I heard from the news that some... I don't know what sort of specialty are these doctors really, because if they choose to work in our department, then most probably if they are specialists, they will be engaged in the emergency medicine training. But if they are fresh graduate, then they have to. I don't know whether they choose to work in our department or not, because it is it is quite a busy department, and even the local graduates sometimes refrain from joining the accident emergency department. I remember when I come back to the public hospital. In the past, I was doing a private practice, but I just joined in the public hospital for a few years because my boss said, we are running short of manpower. So please come back to help. So I go into the emergency room again after my graduation. My first job is in the emergency department. So I'm wondering whether the fresh graduate or even the new doctors from overseas are willing to work in such a harsh environment.
All right. I have a Facebook message here from Michael, and he says, really, 20 medics from the UK and dozens of medical staff from Guangdong? I would be embarrassed to report that if I was one of the recruiters. What does medical staff even mean? And that message is from Michael. Dr. Lam? So we're talking about how useful this GBA healthcare talents exchange program will be. In your view, how helpful will it be? I mean, just now, Dr. Lee, he said they will mainly be for geriatric wards.
If you look at the numbers, the shortfall of doctors in the hospital authority numbered in the hundreds, and the shortfall for nurses numbered in the thousands. So, maybe about 70 or 80 doctors and nurses coming to Hong Kong. There's a very small number compared to the shortfall if you look at it that way. But say if you are working in a department, say of anesthesia, where you originally have nine specialists, and now you have only about 6 because 3 has gone, and now they're giving you 2 more, then it helps. So it depends whether your department has someone coming to assist. But overall, I think it's just not useful just to look at 80 doctors and nurses from the mainland and 20 doctors from the UK. We must take a more global view, and that is we have roughly 590 fresh graduates from Hong Kong every year, and we usually have roughly 40 to 80 doctors passing the licensing examination and joining the service in Hong Kong every year. So that makes up to well over 600, and together with our doctors from mainland China and also from the UK, that adds up hopefully to almost 700 in the next year or so. So that is a number we are looking at. But at the same time, the attrition rate is high in the past few years. So to retain talent is again something that the hospital authority has to put a lot of effort into it. It's just not useful just to look at the number from a particular area, but we must take a more global view.
You say retain talent. What are you thinking about? Pay rises, promotion prospects, better working conditions? All of them maybe, but I mean, which is the real priority?
I did a survey late last year on the same issue, and almost all doctors and nurses mentioned that the workload in the hospital authority is overwhelming, and for many that is the chief reason why they left in the first place. Now, that is not easy. So if someone from your department leaves, so those remaining will have more work per person, and that increases the intention to leave. So this is a vicious cycle we must stop. Otherwise, people just keep leaving, and then the department will have less and less doctors and nurses. That's why sometimes if you employ someone from abroad or from the mainland China, and they have a contract that they have to stay here for, say, 3 years, otherwise they have to go home, go back to England or mainland China, where they won't have a license here, then that is a bigger incentive for them to stay, at least for those 3 years. So it is something we may have to consider, and we may have to do more, so that at least some portion of the department have a greater intention to stay behind. Now, but that is one thing. Another issue is about the management of the hospital authority. Frontline doctors, if you ask Dr. Lee, he would probably tell you how he feels about the relationship between the management and the front line. It is not always in very good terms, and if people think that they are not well treated by the management, then they tend to leave. Well, again, I'm not saying hospital authority is really a bad employer, but if that is an impression that you give your employee, then there is a lot you have to do about it.
Well, let's ask Dr. Lee. I mean, is there an issue with how the management treats its staff in the hospital authority?
Yeah, it is really difficult for me to comment because I'm still under employment of HA. But I agree with Dr. Lam's comment. It is now time to somehow reform the management to see whether there is anything wrong from inside out. And then we have to do some drastic reform of the management of the hospitals. And I believe that besides the measure to recruit new blood from overseas, we have to look also at the local graduates, whether we have to retain them in the public sector to help out for the time being, because we are running short of people. In our department, I can tell you, in the coming few months, we have one consultant immigrating to UK. We have one senior, at least two senior doctors going to live in UK, and also one young doctor immigrating to US in the coming few months. So we are really running out of people. People are running out not only from the public hospital, running out to other places. So it is a difficult situation. If the local graduates, after their training in the medical school, they can help in our public sector for a longer time. This is what our health authority have been saying. They may extend their internship number of years, and they may extend their contract to make them to compulsorily stay in the public sector. And even the health chief has said, if necessary, we may think we have to do some compulsory employment of doctors, even from private sector in the public hospital, to do something more drastical to retain the manpower here.
And it's not really about, if they emigrate to the UK, the salaries in the UK will be lower than Hong Kong, so it's not really about money, right?
Yeah, because of the whole atmosphere here, I can see after the COVID pandemic, many people are leaving. I don't know the reason why. Maybe you can tell me more, because I'm just engaged in the medical sector. But I'm thinking the brain drain now we are having, really in all sorts of professions. The government has to do more. As our CE of the government said, we have to get more people coming. This is an urgent need in every sector of Hong Kong. So I think the government have to put more effort into that.
All right. I have two more emails here from our listener. One of them is from Brett. He says, when I've gone to a public hospital's A&E over nearly 4 decades now, there has been no waiting. For example, after serious road traffic accidents, after losing consciousness, after an injection resulted in my head bouncing off the floor in my GP's surgery. And those times I arrived at A&E conscious, I have seen it is always crowded. My impression is that most folks go there for reasons that are neither the result of accidents or are emergencies. The mention this morning of people going to A&E because they have a fever or the flu seems to me to be perhaps a symptom of the root disease, which is the need to see a doctor for seemingly absolutely every single thing. And that message is from Brett. I have another one, but this listener didn't leave her name. It says, after tragedies, Hong Kong is so fast to offer up remedies, but are these actually carried out? Hong Kong's problem with accountability impacts us tremendously, sadly. And those are the emails from our listeners. Dr. Lam, I just want to go back to some of the measures that were suggested on this program, where we talked about, earlier you talked about how there needs to be a change in the triage system and people need to rely more on family doctors. But your suggestion, it actually takes time for people to change their mindset. But for now, as a short-term measure, what do you think is the most effective measure to prevent another tragedy from happening?
Now, I heard earlier on that other colleagues mentioned about technology, and that is certainly something we can look at. We have wearable devices that measures your blood pressure, pulse, and your oxygen saturation. But how that fits into the emergency department is something for the authority to think about. Do you really have enough manpower to monitor the basically hundreds of extra patients waiting outside before they see a doctor? And how technology might be able to assist in triaging and also monitoring those people is another matter. the technology is there, it's possible, but whether we can use it is another matter. So technology is one thing. And another thing is, I would suggest seriously that people go to emergency department for illnesses if possible, get a family member or a friend with you. So at least there's someone to look after you in case things happen. Or at least they can raise their hand, raise the alarm that my friend or my mother went to the toilet for 10 minutes. She hasn't come out yet. Can the nurse or other people help to find out what happens inside? So those are the things we can do immediately.
Yeah, okay, and we give the last word to Dr. Aaron Lee, who's working in an accident and emergency department. What advice would you give to patients coming to an accident and emergency department?
Yes, I agree totally with David. Yes, ask somebody to accompany you is one of the ways. I remember we have advised people coming to see the accident emergency department during the COVID-19 outbreak. One of them is to ask a relative to accompany you, because nobody may have time to look after you when you stay here for a long time. You bring enough food, you bring enough drink, so that you don't have to leave the department, so that we can call and then you can come in as quickly as possible in our department. This is some of the ways to prevent tragedy from happening.
All right, Dr. Lee, we'll have to leave it here for now. Thanks again for joining us this morning. That's Dr. Aaron Lee, an emergency ward doctor. Many thanks also to Health Services lawmaker Dr. David Lam.